compulsions, sexual compulsions, when they get started on some of the dopamine activating medications. That happens. And then this last one here at the bottom, down at the bottom here, says sexual dysfunction, and the range there is from 2 to 90%. And that covers pretty much the whole percentile spectrum. The difficulty here is that there aren't as many studies done on sexual dysfunction in Parkinson's disease. If you want to pick the one area where there's the least amount of research done, that would be it. There's more done on loss of sense of smell and taste and other sensory changes than there is on sexual dysfunction. Yet when you ask people about what's impacting their relationship the most, it's not being able to no longer appreciate my wife's cooking, it's this, right? So the challenge is there are different degrees of comfort asking about sexual dysfunction. There are different questions that are used to assess for it. So really the better studies would put it closer to about 90%. So the vast majority really seem to have troubles. And we know that if you take one or more of those things, anywhere between 60 to 80% of people with Parkinson's at some point in the course of the disease process will experience those things. Depression, anxiety, cognitive problems. So again, this is not uncommon, right? It doesn't happen always, but almost always. And when you ask folks about it, it is the thing that causes the most disability. It also goes along with the areas that are the hardest to treat. So if you ask neurologists and other providers about treating the motor symptoms of Parkinson's, well, sure, we've got medications for that. We've got deep brain stimulation. We've got other surgical techniques. But how do we get someone over that apathy syndrome? Much, much harder, much harder. And also, when you ask people about what in their disease affects their life the most, these tend to be the things. And in the order of cognition first, in terms of I can't do the things that I used to do, my judgment, my reasoning isn't the same, I can no longer manage the finances or make decisions around that, mood, intimacy, and sexual functioning. Those are the four things that impact people's quality of life the most and more than the motor symptoms, typically. I'm probably going to skip over this fairly quickly. I mean, you've probably all got a working knowledge of what happens in Parkinson's. The two big areas to focus on are the frontal lobes, which are this part here, so the area kind of right behind the eyes and up on the top around the forehead, and then the basal ganglia, which are the deeper subcortical structures that are involved in movement and regulating and initiating movement with the frontal lobes. And the chemicals that we're most interested in are dopamine, but also serotonin and acetylcholine. So you know a lot about dopamine if you're on things like Cinnament or other related medications, but serotonin, we usually think of that with the antidepressants, right? That's what works on serotonin and a few other things. Acetylcholine is another key chemical that's involved in the brain, mostly involved in cognition, so in thinking, and speed of processing, and memory is a big component for acetylcholine. So in Alzheimer's disease, which is marked by memory loss, one of the first symptoms, acetylcholine and the medications that are used to treat it, Aricept, Exelon, really work on that chemical as well. So those are all important. I usually put this up here to highlight the fact that this is a complex process, right? And we think of Parkinson's as a frontal subcortical degeneration. So again, the frontal lobes, those subcortical deep brain structures, well, it's not as simple as that. And you've got these 5 circuits that are involved, and some of them are overactive, some of them are underactive, some of them are doing too much of something and not enough of something else that they should be doing. And it's this kind of complex flow chart where, and you probably can't see that well out there, but complicated disease, complicated process, tough to treat. That's the bottom line on that one. So let's talk about the cognitive changes. And I know it looks to me on the screen here that the red is very difficult to read, so I'll take you through this. So the things that change in Parkinson's disease, and again, it's different than Alzheimer's disease, it's different than other dementias. And I'll pause here for a second because every time I use the word dementia, I am reminded that there's still a lot of confusion around what's dementia, what's Alzheimer's disease, what do those terms mean? And dementia is just an umbrella term that would signify changes in your thinking abilities, attention, concentration, memory, that impact day-to-day life, right? So your ability to do the finances, to drive. Driving is a big issue that I talk about with a lot of folks. So that's all dementia is. Cognitive problems that impact day-to-day function. right? And Alzheimer's disease is the most common dementia. There is a Parkinson's dementia that happens, and there's also Parkinson's mild cognitive impairment. And it looks different than Alzheimer's disease, right? So Alzheimer's disease, first sign is memory problems, language problems come in next, and then there are some other things that change as the disease progresses. With Parkinson's disease, you really see bigger changes in the frontal lobe functions. And those are, up in the top here, if we look at attention, so simple attention is very much intact. So people with Parkinson's can fairly easily follow along with the conversation. Pace might have to slow down a little bit, but reading, again, a little slower, but can do it. But when we do more complex things like pay attention to two things at once, or pay attention to one thing while ignoring something else, or holding multiple things in our attention and working with them, that's where the changes really seem to happen. That goes hand in hand with some of the executive functioning deficits. So people with Parkinson's typically can kind of abstract out. They can think about, if I give you a couple of words like a piano and a drum and tell me, well, how are those similar, right? They're both musical instruments. There's this larger abstract concept that unites them. Big picture kind of thing, right? People with Parkinson's can certainly do that, but then if you ask them to switch between that and another task very quickly, that moving from thing to thing is much, much slower and much more impaired. Or, again, paying attention to two things at once and going back and forth between them, multitasking, right? We all overestimate our abilities in multitasking, but it's particularly true in frontal lobe changes where that's very hard. Planning, right? So thinking about the future, kind of what's coming up, what do I have between now and then, what do I need to do to get ready for this? And also kind of the piece of recognizing the emotions of others or the intents of others, that is changed. So that's going to come in very important here shortly. Language abilities, some parts change, some do not, right? There are vocal changes that most people know about, where there's this softening and quietness of the voice, hoarseness, actual ability to remember the names of objects and come up with the names, to retrieve them, relatively unimpacted or intact. If, though, you change gears and say, now, I want you to tell me all the words that you can think of, generate as many responses as you can, verbs or words that begin with a certain letter, and some of you may have done this test in the past, that's very difficult, that kind of initiating and generating multiple responses. What's interesting is if you change the rules and say, now tell me all the animals you can think of. People with Parkinson's do great, right? Because it's a semantic category, taps the temporal lobes a little bit more. And that's an opposite pattern that you see with Alzheimer's disease, where that first part, the verbs or the letter part's great, but the animal part is very impaired. There are also changes that happen in spatial skills and visuoperceptual skills. So independent of motor functioning, the ability to construct, reproduce, and draw things is pretty intact. So gauging proportions and praxis, as we call it, is pretty intact. But the ability to recognize faces seems like it's changed in folks with Parkinson's, particularly later on, more as you reach the Parkinson's-related cognitive impairment, possible dementia stage. In memory, it's mixed. There are some things that are impacted and some things that aren't. I could probably sum this up by saying, if you break memory down into 3 stages, where number 1 is that you need to get information from the outside world into the brain, number 2 is that you need to keep it there, and number 3 is that you need to bring it back out when you need it. That's kind of memory in a nutshell for short-term recent things. And for folks with Parkinson's, the deficits come in part 1 and part 3. So it's harder to get things in, which is usually why we tell people, if you're going to communicate something, slow the pace down, make it shorter kind of duration, and well organized. That way, more of it's going to get in, right? And we also, it's critical to assess sensory changes, hearing and vision, because that, if you can't see it and can't hear it, you can't remember it, right? So also, people with Parkinson's need a few more passes. So if you've got a grocery list, you might have to read that or write it down a couple of times. Recall seems to be affected mostly from the retrieval piece, that it's in there, but it's hard to access it. You can come up with every other name but the one that you want, right? And with some cueing and some prompts, saying, well, some of those items were in the frozen food section. Oh, right, ice cream and peas, and right, okay. That seems to be better in Parkinson's folks. Memory for upcoming things seems to be impacted, maybe more so than short-term memory, so we call prospective memory, and then memory for sources, so where you heard something or where you saw something seems to be more affected. And the interesting thing about all these things, with the recognition piece being intact, the ability to remember how to do things being intact, is all of these components really map onto the frontal lobes versus the temporal lobes. So this really is kind of the highlight of the frontal subcortical picture. So that's a brief summary of the cognitive changes that happen in Parkinson's. And the biggest thing, again, is that it plays into the apathy syndrome. That ability to plan and initiate behavior is reduced. And there's a piece of it that is mood related, where people would say, it's such an effort to say anything now, and nothing seems that important. What's the point? And that sounds like someone who's depressed, right? And some of it is just this lack of drive. There's I had a patient tell me once that I feel like the lights are on, but the voltage is low. And I thought that was a pretty telling description. And so with the cognitive impairments, we know that many people will get that to different degrees. And also we know that many people with cognitive impairments also have depression, anxiety, and fatigue. Mostly this tends to be in the mild to moderate range. So it's not severe, profound, I can't get out of bed, I'm thinking about ending my life kind of depression. But it is there, and it certainly does impact quality of life in a big way. It also seems like it's equally distributed across the early stages of the disease, the more middle stages, and the later stages, but the type tends to be different. So in the early stages of the disease, it's what we would call exogenous or kind of reactive depression. That you get this diagnosis of a neurological disease, life is not the same, there's no cure, there might be some treatments that help, maybe for a while, but this is going to get worse. Would you likely be depressed? Sure, that would make sense. It's kind of a reaction to something that you didn't plan happening, right? But what happens is as the disease progresses on, it becomes more what we call endogenous, which means it's really based from the brain, that the structures have changed. The structures that produce chemicals like serotonin and norepinephrine and dopamine aren't doing that anymore. They're not functioning the same. And people aren't having that same kind of adjustment reaction. They're really just not, the neurobiology of depression is really the major player here. And very, very interesting, the symptoms of major depressive disorder and Parkinson's disease overlap a lot, right? So there's people with depression are slow. They don't move very quickly. They don't think as quickly. They have concentration problems. They don't sleep well. Their appetite's disturbed. And they don't have a lot of desire to have intimate relationships or intimacy with their partners, right? A lot of similar symptoms to Parkinson's there. So there's a question when we look at sexual dysfunction and intimacy, is it the depression? Is it the Parkinson's? Is it kind of a 1 + 1 = 3? So an additive effect of both of these things, which is probably more likely the case, which again makes things much more difficult to treat. And you need multimodal treatments. So Viagra isn't just going to do it, right? That's not going to be it. The antidepressants aren't going to do it. You need more than that. So let's talk for a minute about sex and intimacy. And one thing that I learned very early on doing this talk is, again, people have different levels of comfort talking about this. And usually in a large group of people, I'll have people shout out the words like, erection and vagina just to, get over some of that a little bit. We won't do that today. I'll spare the two of you who are here that... unless you want to, you're welcome to, but you don't have to. Again, I will respect your questions if you have them, and I will respect your options not to ask questions. You can always send them to me via email, or you can call me. That's fine. And hopefully, again, this is just a point to begin the conversation, either with your providers or your partner, whoever it may be. So the first thing I do want to address are some myths about sexuality and the lifespan. And most people, I remember teaching undergraduate psychology courses, and you'd start talking about sexual functioning and, with people in their 70s, 80s, and even 90s, and you could just see the faces of students in their teens and early 20s change dramatically. And there was this, I don't want to think about my grandparents having sex kind of mentality, but I usually turn that around and say, well, when you're a grandparent, would you like to still be having sex? And they usually say, well, yeah, but that's different. Well, no, it's not, right? So the first myth is that older adults do not want to remain sexually active. And if you look at the literature around who is sexually active, I mean, obviously this is something that continues 50s, 60s, 70s, 80s, 90s. There's a myth that if older adults are having sex, it's going to be dysfunctional. There's going to be something wrong with it, right? It's going to be bounded by problems and difficulties, and it's going to be medicalized in some way, shape, or form. Absolutely not, not always. There's another myth held by providers as much as patients that sexual dysfunction in older adults cannot be treated. That if you've got it, well, sorry, hopefully you enjoyed it in your 20s and 30s and 40s, because that's kind of all you got. And on top of that, if you have a neurological problem or cognitive issues, then, well, maybe you shouldn't be having sex because you can't provide consent, or there's lots of myths out there. I was shocked when I would ask folks kind of who are providers and treating people with neurological disease how they felt about this. Discomfort sometimes. Another big myth that has, if you've followed some trends in the news, particularly in Hawaii, Florida, and Southern California, sexually transmitted diseases are not spread among older adults. It is the population with the most rapidly growing HIV and HPV rates in the population. Slowing down a little bit as there's some education and some outreach for this, but it's still a major issue. And when you put that in the context of other medical problems that tend to happen in later life, it becomes a bigger issue in some ways. And then one that I work with a lot with folks is that by the time you've reached your 60s, 70s, 80s, 90s, any sexual issues or intimacy issues you have, well, you've probably resolved them by now. Absolutely not. And I will tell you in a second that if you had problems with intimacy and sexual functioning in your 40s and 50s, and then develop a neurological disease on top of that, much harder to treat. So the take-home message there would be the earlier you intervene, the better, right? But having a neurological disease does not mean that you can't intervene, right? The other barriers, again, come from the side of professionals. And a lot of research that is around sexual functioning and intimacy has looked at how often do doctors and nurses ask, and they don't. The vast majority of the time, it's the last thing that will come up. And doctors are great at saying, well, yeah, but I've only got 12 minutes, and I've got to focus on the motor components and the medications and any financial issues and the cognitive issues. There's no time. Well, no, you're not prioritizing it. And that's kind of the bottom line. And I've actually talked to a handful of folks, none at Evergreen or none at Virginia Mason, who would say they don't want to know. My job is to manage the motor symptoms and the medications. Certainly happy to talk with you about your cholesterol and your blood pressure, but erectile dysfunction and lubrication problems, nope, not doing it. And again, they have their own biases, their own discomfort. You would probably cringe at the degree of training most neurologists and other primary care providers, even psychologists, get around sexual functioning and how to talk about that with folks. Lots of shame and lots of embarrassment still for providers, right? So when we look at what is available for research around intimacy and sexual functioning in Parkinson's disease itself, and again, there's not a lot out there, and there's not a lot coming out either. The studies that are there, and I haven't seen anything that's been new or that different in the last, at least the last year, maybe 18 months. We do know that you are more likely to have sexual problems and intimacy problems, and I do want to talk about the difference between those two in a second. The older you are, the more severe the disease is. If you have other diseases, such as diabetes, other vascular problems that change blood flow, if you have previous sexual dysfunction, and if you have comorbid or combined depression. So if you have one of those on top of Parkinson's, you are bound to be in that 90%. If you've got more than one of those plus Parkinson's, chances are there's some degree of difficulty or dysfunction, meaning change in function, in intimacy and sexual functioning. And one of the biggest things that we see and we hear about is decreased drive. So not interested, right? Not even thinking about it. It's not, even though my partner is, my spouse is, it's just not on the forefront of my mind. Kind of take it or leave it, probably leave it. And that really does seem to be multifactorial in terms of why that happens. So one is the changes in the chemicals in the brain, like dopamine, serotonin, norepinephrine. There's a endocrine component to this. Some folks with neurological disease do experience changes in testosterone, estrogen, progesterone, FSH, other hormones that are involved in that. The neurobiological piece, so again, the frontal lobes, the reward system in the brain that sees intimacy and sexual functioning as a rewarding and meaningful activity. Other hormones, cortisol levels change, which change stress response and change sexual arousal cycles. Autonomic nervous system changes, things that regulate your body temperature, sweating, metabolism, pain. Most people would say that if I'm in chronic pain, having sex is the furthest thing from my mind, and it's hard to be intimate. I feel irritable a lot and don't feel real open to any kind of advances. And then depression, right? It's a hallmark of depression is decreased libido and difficulties with intimacy. The other things that seem to be specific to Parkinson's are the motor changes, right? So people with both rigidity and tremor, mobility in bed, mobility during sexual encounters and functioning changes, and that becomes much more difficult. Most people that I've talked to would say that they don't feel very attractive, right? I'm on these medications, I've got this condition that makes me sweat, I've got excess saliva, I feel like my smell has changed, and I've actually heard that in relationship to the medications on occasion. I don't know if anybody out there has experienced that. It's a pretty uncommonly reported symptom, but it does happen. And gait disturbance. I don't feel sturdy and kind of as fluid as I used to be. Why would this person want to be with me, right? I hear that a lot. Masked face, right? So that decreased expression, that kind of flattened affect. And I remember well about 10 years ago, the first time I did a presentation to a group of patients with Parkinson's disease and being used to reading facial expression and the nonverbals and thinking, oh, this is entirely different. This is I don't know if they're following along or not. And you can imagine with sexual functioning, if you're, making some signs that, I would like to have sex, I'd like to be intimate, and you're not getting much back, well, it's hard to know, right? So that's where clear communication comes in. A lot of folks, we talked about, folks have sleep disturbance, which leads to people sleeping in different beds. And that's hard to be spontaneous. You need to plan things out a little bit more if you're separated and not sleeping in the same place. Fatigue, just by the end of the day, I'm exhausted. The person with the disease, I've been fighting all day to get things done that I need to get done. I'm tired. The caregiver, care partner, I've been running around doing everything that needs to be done around the house. I'm still working, helping with transfers, other mobility issues. I'm exhausted. It's the last thing that we have time for or energy for. And that kind of fits into with change in roles, that couples get into fairly well-established roles in terms of who initiates sex or intimacy, when intimacy happens, who does what when, and when it happens, right? So couples that only have sex at night, well, if you do have fatigue, that's going to be much harder. And then change in roles, too, in terms of who discusses these things. If there's an issue, who usually brings it up, right? I would take a second, too, to mention increased sexual drive. That does happen, and there's a question mark here by the relatively rare comment. Hard to know because it's one of those things that people usually do not mention, and the only time that we really see it is when it becomes so egregious, someone who's pestering his wife 8, 9, 10 times a day to have sex, or has taken up, collecting pornography, or legal charges have been brought about. It almost always comes from treatments. We see it with the dopamine activating medications, probably see it more often with surgery, unfortunately. Some of the DBS and other piledectomy surgeries seem to give rise to this. And the bottom line is that it's probably organic. It's either chemical or structural. And you can modify it by decreasing dosages or adding some other things in. But it does happen. And it's as problematic, if not more problematic in some ways, than decreased sexual drive. Goes along with the impulse control disorders that happen in Parkinson's sometimes, gambling, pulling of hair, and there's a few other things that people do repetitively, impulsive shopping. So does lead to question 2 that, is sexual dysfunction really related to just Parkinson's, right? And if you look at who has what in terms of problems with sexual functioning and intimacy, you'll find similar levels, that kind of 2 to 90% range, in older adults that have arthritis, certainly in people younger and older that have depression, and those that are unemployed. So again, just not feeling good about oneself and not having that same connection. And here too is a good time to make that distinction between sexual functioning and intimacy. So, I mean, most people would say they've got a pretty good idea around what sexual functioning is, right? I mean, there's the ability to maintain and achieve an erection, reach orgasm. For women, it's, the ability to achieve orgasm as well as lubrication and the act of having intercourse. But intimacy is a different animal. And when you ask people what intimacy is, there's a lot of, well, it's sex, right? I mean, it's having sex. It's being sexually intimate. Well, yes, that's a form of intimacy. But, usually we think about intimacy as, you're letting your guard down. You're letting somebody in. And that can be through communication, through talking. It could be through holding hands. It could be just sitting close together on the couch, cuddling, hugging. All those things are intimate. And communication tends to be an area where people have the most difficulty. They can be sexually intimate, but really talking to someone about their insecurities or fears or what's a problem, that is a different form of intimacy that's much more difficult. Because people have very, very deeply entrenched beliefs, about, good girls and boys don't talk about this, or we shouldn't have this kind of problem, or if we do have this problem, I should be man enough to figure out how to take care of it. I hear a lot of that, too. And we do know, too, that men and women have different ideas about intimacy, and not unsurprising, they have different kinds of problems when you look at sexuality and sexual functioning, per se, in Parkinson's, right? So the biggest issue for women is arousal problems. So the ability to achieve lubrication, to really be interested in having sex and physically capable of doing it. Also, about 3/4, that first number is 88%, if you can't see it. The next number at 75% is delayed or absent orgasm. And there are some, whether you have Parkinson's or not, that number is surprisingly high for women. Not that high, but high. Low desire. So that piece of just not wanting to be sexually intimate, about 47%. And then sexual dissatisfaction, that yes, we can have sex, but it's not the same, it's not enough, it's not what it was, I'm not happy with it, about 38%. Contrast that with men, whose biggest concern is erectile dysfunction, right? About 68%. Sexual dissatisfaction is almost double that of women at 65%. Premature ejaculation at 41%, and delayed or absent orgasm at 40%. So again, for a lot of men, intimacy and sexual functioning, intimacy maybe less so, but sexual functioning is really identified by the ability to have an erection and have intercourse. And that is it, right? So when you talk about other things that you could do that are not just completely dependent on intercourse, people point to that as, yeah, we could, but that's not the same, right? So, and that's where some acceptance comes in, and we'll talk about that in a minute too. So treatments, if that's kind of how the picture looks, and we know that most people have this, we also know that most people do not present talking about it until later in the course of things. What I usually tell people is the first thing you need to do is you need to talk to each other, right? So whatever you and your partner, with whom you are intimate or sexually active with, whatever you guys decide is what you want and what works, that's up to you. There's no doctor, psychiatrist, psychologist, nurse who should pass judgment on that. As long as it's consenting and you're not putting each other in great risk, well, whatever works. If it's intercourse 8 times a day or once a month or holding hands every day, whatever it is, that's fine. But you have to be able to talk about this with each other. And if you can't, That's why there are couples counselors, marriage and family and sex therapists out there to work on basic strategies for communication. And again, there's that bias of, well, if you've been married for 40, 50, basically up here is the model of the brain, right? And as things progress on in Parkinson's disease, and it goes from just a purely kind of subcortical to a frontal subcortical, there are also things that are called Lewy bodies that occur in Parkinson's disease. And there's a whole separate kind of condition called Lewy body dementia that occurs. And there's some speculation that all of the cognitive change in Parkinson's and Parkinson's dementia is really kind of Lewy body disease that takes a different pathway in a different form. And it affects the parietal lobes back here, so in the back part of the brain. And what you see in Parkinson's is it seems like there is a disturbance in the ability to gauge kind of proportions and depth, and also being able to visually integrate information. So vision's not impacted. It seems like the brain's okay, which is a little different than Lewy body disease, where there's actual changes in the occipital lobes way in the back. But it seems like it's that ability to kind of synthesize visual information that's changed. It seems like it happens more in the mid stages of the disease for most people, not for everybody, but for most people. And it really, again, it seems to be independent of vision. So it's really the brain, the parts of the brain that organize and integrate and analyze visual information. And it likely, the studies, I haven't seen the big studies that would say this, but it likely corresponds to the presence of those Lewy bodies, which is a particular protein that accumulates. It's probably due to that. And the big thing about that is, when people, where it probably comes into the most forefront is risk for falls, right? So people can't judge the distance down from a curb, right? How far it is from where they are down to the street, or run into things. Somebody's already at increased fall risk because they're unstable and they're not moving well. Now they can't see the environment that well. And I also usually see it or count it very heavily when we're looking at things like driving, right? Because you want to be able to scan your environment quickly, analyze what's happening, respond appropriately. And in Parkinson's, again, we're looking at reaction time changes, mobility changes, and we put visuospatial changes on top of that, becomes a concern. If it's the first thing that presents, so if somebody comes in and they don't have very many motor symptoms and they don't have a tremor or other signs of Parkinson's and they have just purely visuospatial problems, we start thinking about Lewy body disease more than Parkinson's. Does that answer?
Thank you.
Great, thank
Sure.
you very much.
Sure.
Okay, so we have a few more sites to check in with. And I think that was just, was that Port Townsend?
Mm-hmm.
Okay. Sandpoint, Idaho. Any questions at Sandpoint? Okay. How about Spokane? I know we normally get quite a few people in Spokane. Any questions from Spokane? Okay, I'm not sure we're connecting, so how about Tonasket, North Valley Hospital? Okay, and our last place to check in is in Walla Walla.
Spokane does have a question.
Oh, good. Okay, Spokane.
Okay, here you go.
Can you hear me?
Indeed.
Okay. You had said earlier that both partners oftentimes had problems. And I found that the hardest thing with Parkinson's, you never know when you're going to have an up or a down in your cycle. And to plan out something is is very difficult, because maybe you planned it and after dinner or what have you, and then your medicine isn't working right, so you don't move very good. And the spontaneous is the secret, I think, for a person that has Parkinson's, and they feel the need, and so it takes a lot of understanding on the partner's part to be able to honor that period of time. So is this correct, or?
Oh, you were more than correct. Yeah. Yep. No, absolutely. I agree with you. I think the spontaneity is critical. And that flexibility is important, because your plans may not work out, right? And as predictable as some things in Parkinson's are, response to medication may be mediated by, food you've eaten, how you slept the night before, your mood, a variety of things. So best intentions that, after dinner we're going to do this, this, and this, but it may not work that way. So no, I fully agree with you, and that's one thing that I try to work on with people, is that, the chores can get done another time, right? I mean, you maximize the moment and do what you need to do when you can do it. You're reminding me, my daughter, who is, as she was apt to remind me, she's 2.5, is fond of a book called "Someday is Not a Day of the Week," right? So putting things off to someday, not on the calendar anywhere. So do it when you can do it.
Okay, thank you, Spokane. Any other questions there? Okay, I'll just call out again Tenasket in case we missed you, North Valley Hospital. And finally, Walla Walla.
No questions, thank you.
Oh, you're welcome. Well, that completes our list of remote sites. So again, we just want to thank you, Dr. Rhodes. That was really a great presentation, and thank you for providing your email. So you've generously offered to answer questions should they come on email. And I don't think we have any other announcements at this time, so that'll conclude our program for March. And again, in April, we'll be having Dr. Sami, I believe, and the topic is not yet listed, but it will be on the Northwest Parkinson's website, and also probably on the Parkinson's Research or Resources of Spokane site as well. So please feel free to check those, and we'll see you next month. Thanks.